Welcome, ladies and gentlemen and guests. This is the FilterLIFE podcast, and I'm your host, Dan Holmes. I'm a U.S. Navy Special Operations veteran and kidney warrior living with kidney disease linked to toxic chemical exposure during my time in the Navy. On this podcast, we sit down for real, one-on-one conversations with guests from all walks of life, patients, donors, caregivers, advocates, and medical professionals, creating space for people who want to share their story and for those who want to share knowledge to our kidney community. FilterLIFE is about more than kidney disease. It's about how we filter through fear, information, opinions, and uncertainty so we can protect what matters the most, our health, our mindset, and our future. Some of these conversations are going to be raw, some are going to be heavy, and some are going to bring watery eyes along the way. So please use caution if you're listening to this at the gym where you have to explain why you have watery eyes or while driving. But if you're ready for honest connection and real life takeaways, people who've lived this journey, hey, sit back, relax, and let's get into it. And let's filter life together. Dr. Beck, thank you. My name is Dan Holmes. I'm here with the Enlisted Kidney Foundation. I'm the founder and CEO of the Enlisted Kidney Foundation. Today, we're going to interview Dr. Laurence Beck. Dr. Beck, thank you for joining Enlisted Kidney Foundation today. It is an honor to sit here with you today and talk kidney disease and just have an open discussion and conversation around the world of membranous nephropathy and rare kidney disease.
Great. Thank you for inviting me, Dan.
No problem. Now, for the world that doesn't know Dr. Beck, I'm going to give you a quick little introduction about who you are and some of your amazing accolades. But Dr. Laurence Beck is an associate professor of medicine and practicing nephrologist at Boston Medical Center and Boston University School of Medicine. He's earned his combined MD and PhD from Harvard University before completing his internal medicine residency and nephrology fellowship at Boston Medical Center, where he continues to practice today. Dr. Beck worked alongside Dr. David Salant to identify the first target antigen and autoantibodies in membranous nephropathy, a discovery that fundamentally changed how the disease is diagnosed and treated. His ongoing research and clinical work continues to focus on membranous nephropathy and other glomerular disorders, bridging the gap between laboratory science and patient care. Again, thank you, Dr. Beck, for being here with us today. I know our community of followers is really, really, really excited for this interview. So before we get started, I want to let you know that we do have our membership program on Patreon. And our FilterLIFE members, we solicit for questions to ask during these interviews. And our Patreon members keep us going, man. They keep the Enlisted Kidney Foundation funded. They keep us being able to do all of these type of events and things like that. So we took a question from one of our Patreon members, our FilterLIFE members. And if you don't mind, would like to read you a question. And if you can answer it for one of our patient members here. Question is from Stephen H. At what point in membranous nephropathy treatment should a nephrologist be offering Rituximab? And is there any special language they should use to help get it approved by their insurance? So like, for example, should they call it a life-saving treatment, or should they have to put it into some kind of emergency medicine code?
Yeah, so that's a good question. And I think we'll get into the basic treatments of membranous nephropathy in a bit, but briefly, in the 1980s, there was a very toxic regimen, which is still used, that involved a chemotherapeutic drug called cyclophosphamide. You alternated that with high-dose steroids for 6 months, and it works, but it's too toxic for most people. And then came along some medicines like cyclosporin and tacrolimus, which are good at getting the protein in the urine down, but they don't have as good long-term effects. And then came Rituximab. So there were pilot studies around the turn of the millennium, around 2000. This is a drug that kills B cells and was first used for B cell tumors like lymphoma. And people thought, because membranous nephropathy involves B cells and antibodies that attack the kidney, that it would be a good treatment. So there were small pilot studies that worked very well. and then larger observational studies with 100 people showing that it worked very well. And it wasn't until what was called the Mentor trial out of the Mayo Clinic in Toronto that showed that rituximab was actually the superior treatment when compared to cyclosporin at putting patients into a complete remission. So that was published at least 5 or 6 years ago. I don't have the full date, but it was a big splash in the membranous nephropathy world. And it really established rituximab as the first line agent. And that's the terminology I would probably use. This is the first line treatment. It's recommended by our international glomerular disease guidelines called KDIGO, Kidney Disease Improving Global Outcomes. And the current trials that are ongoing, clinical trials in membranous nephropathy, are just using amped up versions of rituximab. So it really is the key treatment these days. And yes, insurance companies can be funny, but I've had good luck with it. I know that's not true, certainly globally, but in the United States, I think it should be. A nephrologist and patients should be able to push the insurance company to approve this because it really is the first line treatment at this point.
Awesome. Thank you so much for that. I'm sure we'll get into a little bit more about rituximab and the usage of rituximab and pretty much when it's appropriate. So to answer Stephen's question, at what point in your treatment regimen should rituximab be introduced? And I think the answer is it should be the leading treatment. It should be the first thing that we reach for off the shelf. Is that accurate?
So I don't think it's always indicated, and this is the tricky part. And it takes us back to the time before we found in Boston these antibodies to a protein in the kidney filters called PLA2R. And that is a normal protein expressed right at the kidney filter in the glomerulus by a cell called the podocyte. And for some reason, people develop antibodies to that. It's an autoimmune condition in many cases. And the antibodies start targeting the kidney filters, making up deposits. And that leads to gradually more and more protein in the urine, tissue swelling and leg swelling, and sort of all the other downstream events. So before we had this as a biomarker, and now you can get a blood test and measure your anti-PLA2R antibodies, we were just sort of going off the clinical symptoms, right? So before 2009, which is when we described these autoantibodies, we had what was called idiopathic membranous nephropathy. We didn't really know what caused it. We differentiated it from things like, systemic autoimmune diseases like lupus can cause a secondary form of membranous, infections like hepatitis B, certain medications, malignancies can cause membranous, and those all had slightly distinct features on the kidney biopsy, but everything else was called idiopathic.
Everything
else. And when a patient showed up to their primary doctor, their kidney specialist, they often had, 20 pounds of weight gain. They had swelling of the ankles and legs. They had very large amounts of protein in the urine. And the question was, we treat with basic agents, what we call foundational therapy or supportive therapy, like ACE inhibitors, angiotensin receptor blockers. Now we're using things like Jardiance and the SGLT2 inhibitors, water pills, diuretics. But the question is, did that patient need immunosuppressive therapy with things like the chemotherapeutic agent cyclophosphamide or tacrolimus or rituximab? And we didn't have an easy answer because this disease, unlike some other kidney glomerular diseases like minimal change disease, isn't like a quick on-off. Minimal change disease, which happens more in kids than adults, 2 weeks before that person will be fine. And then, they wake up one morning and their eyes are puffy and their legs are swollen.
Right.
And then they often get a pill, prednisone, and that can put into remission in a few weeks. I like to say that membranous nephropathy is the opposite of that. It probably takes 6 months to a year before anyone even notices the swelling, the weight gain. And unfortunately, it also takes a very long time for that protein in the urine to go away. So the dilemma that we have now, that we have an answer to now, but in 2005, a patient comes in with 8 grams of protein in the urine. Is that something that's going to continue to get worse, or might it get better? So now we can test for the antibodies in the blood, these anti-PLA2R, and say if they're there, if we can detect anti-PLA2R, we know that's active disease.
Gotcha.
And it could still be on its way down. So I would recommend at least checking it twice, once and then maybe 3 months later, before the decision is made to start a medicine like
Rituximab
Rituximab,
or something.
because
Pretty
these
aggressive.
suppress the immune system, and they can help the disease process, but they also put people at risk for
A lot of other things.
minor infections. Some people have hepatitis in their bodies, may have like latent tuberculosis. So we need to make sure that we're not going to cause more harm than benefit when we start a medicine like this.
Exactly. Exactly. I appreciate that. Thank you so much for that clarification. That makes a lot of sense. I want to segue real quick into, you just got back from a really, really, really cool event. Unfortunately, I wasn't able to be there this year, but next year, I think we're getting our ticket stamped. So you went to Kidney Week this year in Texas. So I would love to hear a little bit about a takeaway or two that you were able to come home with from Kidney Week in reference to your studies at membranous nephropathy, kind of a state of membranous, kind of where we are with the disease and education and trials and things like that. Yeah.
Yeah, so Kidney Week, some people call it Kidney Christmas. It's it's a chance for certainly American kidney researchers, healthcare providers, run by the American Society of Nephrology, but it's also a global event. We got, 10 to 15,000 people attending this, and it was just in Houston, and
Wow.
it goes to major convention centers across the nation. But yeah, it was last week and ended on Sunday. And you find out everything from new clinical trials that have come out in every aspect of kidney disease to the most detailed research that people are doing and presenting on posters. So we were fortunate to have a late Saturday afternoon session on membranous nephropathy, and I was one of the speakers and organizers. And when we got that time slot, I was just devastated because, Saturday afternoon, college football going on. It was 85 degrees. I felt no one was going to come to this thing, preparing for dinner plans. But we had a 2-tiered auditorium stadium, and, it was quite full.
Packed.
So the interest is
Wow.
certainly there.
Yeah.
And we talked about sort of how the science has helped patients. Then there was something on a session on do we even need a kidney biopsy? I talked a bit about biomarkers and how that informs treatment, and then there was a session on ongoing, like the newer treatments that are upcoming and trials that are going on. And I think since PLA2R, that's the major target in primary membranous nephropathy, they found like 30 other targets, which has been very difficult to wrap anyone's head around, because membranous nephropathy itself is rare.
Right.
Like in the United States, about 10 per million people are diagnosed every year. So that's only like 3,000 people a year. Many of those will be PLA2R, but the rest of them are all these others scattered. So you may have like a few 5 to 10 people with any of these other diseases a year. And it's very difficult to study that, right?
How does that reflect like these clinical trials that are coming out? If you got
Yeah.
you're trying to cast such a wide net, but you're looking for such a small population of people, how are the clinical trials even going to be really, effective?
Yeah. And that's a big issue. And you were part of these discussions a few years ago at a meeting in Arlington, Virginia, because anti-PLA2R as a biomarker is great. And we use it clinically. We use it for diagnosis. We use it for monitoring whether patients are, if the treatment is working, if they're going into a remission. But the FDA doesn't have enough information yet to allow us officially to do that. So, a physician, healthcare provider can use something off-label, right? Rituximab isn't even FDA approved for rituximab. We're using it off-label. Same thing for a diagnostic test like anti-PLA2R. We're using it off-label to monitor disease, and our KDIGO international guidelines recommend that as well. But unfortunately, for official uses like a clinical trial, the companies can't use anti-PLA2R to monitor how that therapeutic is working. So we're trying to gather data globally in an effort called Parasol 2.0 to get enough information to present this to the FDA to say, can we use this for treatment guidelines? So that's the easy one, right?
Yeah.
PLA2R, the majority of patients with membranous. Some trials are even enriching patients. They'll allow a patient with a level over, some arbitrary number
Yeah.
to be in their trial. We're realizing that what does that mean for anyone who doesn't have this type of membranous nephropathy? We can't exclude patients. There aren't enough of them, but we also want a mechanism by which we can know if a drug is working.
Correct.
IgA nephropathy, which is another more common but still rare glomerular kidney disease, has recently benefited by an FDA decision called accelerated approval. So if a new drug comes out, if that study shows that drug can lower the urine protein by more than 30% from baseline, that drug can get accelerated approval and go out on the market, as long as the company finishes their trial and shows that there's a longer term effect on kidney function. So there are a lot of new medicines coming out in IgA nephropathy, and we wish that were the case for membranous nephropathy, but because of the slow reduction of proteinuria, that's not a wonderful target. So we'd rather use something like the anti-PLA2R, but again, what does that mean for someone who doesn't have
He doesn't have
this
that.
form?
Yeah, if so for like me, right? I'm a PLA2R negative. I don't
Mhm.
have the antigen to track, right? So my treatment of MN, as you know, was a little bit more difficult because we didn't really know what it was secondary to. I was originally diagnosed at idiopathic and primary, and then it was, oh no, well maybe it's secondary, and then it was we did the pathologist and saw the labs, and then we entered into the realm of toxic chemical exposure, and that's new. I know we've talked about that before, where we're starting to see some articles come out and some people do some research where we're starting to connect a lot of these toxic chemical exposures to some of these kidney diseases that are prone, and not just kidney cancer. So that's one of the things that is really cool about, this time that we're in, so now patients often crash into this disease. I know it was like that for me when I was diagnosed. Like you said, there's a progression, right, for membranous, and by time I realized I had symptoms that needed to be emergently taken care of, it was almost too late for me, right? The pulmonary embolisms were already growing, the water retention was starting to accumulate already, and then I just crashed into an ER. So I crash into an ER. I don't know what I have, right? I've never done research about membranous nephropathy. I don't know anything really about kidney disease. I thought I was a completely healthy individual. And now I crash into the ER and I'm at the beck and call of my floor doctors and the nephrologists that are on staff there at the ER and those kind of things. The question I have for you is, what's the single, if you had to put a finger on something, the single most important thing that a patient should understand early on about this disease? Because there's a lot of misconceptions out there, and when the doctors throw their hands up, because I still see it every day, I still see them go, I don't really know. Like, we're going to do high dose steroid. I've seen patients getting as soon as they're getting diagnosed, they're getting on cyclophosphamide or they're getting on cyclosporin. There's all these different things that are happening to people at different stages, but yet they're just now being diagnosed, right? So we get
Mhm.
people who are being diagnosed with membranous nephropathy alongside FSGS. And that just tells me that the progression has progressed to now that we have the scarring, and we just didn't catch it early enough, you know? So the single most important thing that a patient should know when we crash into the ER and the doctors come to us and say, man, I think you have some type of form of nephrotic syndrome.
Yeah, that's a tough one in terms of the key thing. I guess knowing that this may be unfamiliar to many doctors uh, is a key thing. And a lot of the work, initial work may need to be done by you, the patient. Um, I've had some people that have diagnosed rare disorders just by Googling their symptoms,
Right.
and I think if people are noticing that they're having weight gain, leg swelling, bubbles in the urine that weren't there, and you put those into Google AI search or something, that's going to quickly come up with, okay, you may have the nephrotic syndrome. And there are multiple different causes, um, some of which have blood tests, some of which don't. Um, but I think it's important to try to let your doctors know that the symptoms may be starting in the urine, right? Because a lot of people show up to an emergency room and have leg swelling, and they'll get an echocardiogram because they're wondering if they're in heart failure. I've had people go through multiple tests, CAT scans of the body, looking for cancer obstructing their, flow of
That happened to me. They were looking
blood
for a
back.
kidney stone that was a fully blocked kidney stone that didn't exist because
Mm.
they were like, you're just swelling with water and it won't stop. So we don't really understand. There must be something blocking it. And that didn't make sense to me. As an uninformed patient, it kind of made a little sense. And that's what got me to the ER in the first place. But yeah, I can totally relate to that.
So I think understanding that an ER doctor might not put things together, because you really have to test the urine. If for whatever reason you get a little dipstick test of the urine, or because you've had abnormalities, sometimes there's even a little blood that's microscopic and detectable. Um, that's not always done. So if you've noticed urinary symptoms, ask to have your urine tested, because the amount of protein is usually massive.
Yeah.
And that will lead doctors down a pathway. There are certain blood tests like anti-PLA2R, but also some other routine tests we do for glomerular diseases that can be done. It's not going to find non-PLA2R membranous. It's not going to find FSGS yet. There may be a up and coming test for other autoantibodies, but there are a lot of nephrotic syndrome disorders that need a kidney biopsy. Um, and the blood clot you mentioned, someone as may show up with a pulmonary embolism, a life-threatening blood clot that has traveled from the lower extremities or even the veins of the kidneys to the lung, blocking blood flow through the lung. And there are other, there are blood causes of that. People don't always think that this could be the nephrotic syndrome. Um, so piecing together these puzzle pieces, hopefully the doctors will think of that. But, in my experience, having seen a lot of patients with membranous nephropathy, that's not the case. So being your own advocate, being curious about your symptoms, I mean, with everything that's available in terms of AI and
Yeah.
ChatGPT, and just Google now seems to be
Yeah. So
everything
that's
is AI.
You just answered my next question. So my next question was like, how can a patient or how can patients better advocate for themselves in the exam room, right?
Mm.
So I think you just answered it. Like, have your urine checked. Um, the PLA2R antibody test that can be done in blood, is that common? We can do that in a regular ER setting. Is it that common now? Is there a specialist that needs to be involved or something with that?
No, I think most hospital systems will can order it. It may go out to a, you know
third
third-party
party or
commercial lab company, but
yeah.
it's not quick. Um, when we were getting it done, it was often a week till the result. We're now sending it out elsewhere, and it comes back within a few days, a little
Oh,
quicker,
cool.
which is nice. So it's not going to be an instant answer. Um,
But it gives us an idea of kind of what to look for. So we're looking for, if you have the symptoms of the swelling, right? The pulmonary embolisms. I actually suffered 8 of those. I had
oh,
8
geez.
pulmonary embolisms. I had a full renal vein thrombosis, an RVT that had a thrombectomy to have to
Ugh.
get it out. And all of that was because I had crashed into the hospital spilling 12 grams, right? 12,000 milligrams of protein. I think any nephrologist would start ears go up after 30, right? 12,000 is a lot. So, I crashed into there, and the advice was never anticoagulation. Nobody understood, hey, we have a patient that's spilling 12 grams. We should probably be put on anticoagulation. And the excuse at the time when I was asking the question was because there wasn't enough research. There was only research that had been done with like heparin, and they didn't have any research done with Xarelto or some of the other Lovenox or some of the other things. So I went through all the trials with all the different anticoagulations to find the one that I didn't repeat the PE,
Mm,
and Xarelto proved for me to be successful. I haven't had a pulmonary embolism since, although I've also gotten my proteinuria under control. So
mhm,
what's working, I'm not sure. I know that the proteinuria, I'm retaining my albumin and those kind of things. So some just real quick advice of something that I would give to a patient that crashes in, that is starting to swell and is retaining a bunch of water, is the very first thing I would tell your doctor is check my albumin levels.
mhm,
Because while you're in the ER, the only thing that can get that weight off of you is to replenish some of those albumin proteins in conjunction with some diuretic, because that's really what helped get the weight. When I went from 215 to 300 pounds overnight, because I was storing all this water, I got in there, and what is the first thing they do? They hook me up to IV water to give me more fluids,
mhm.
right? And then they're like, all right, we're going to give you fluids, and then I'm going to give you a diuretic. And I was like, okay, well, that sounds counterproductive. So it took so long for it to click about the albumin, injection, and let's just do and then the water comes off. You know what I mean? So my first thing is, if you're swelling and you come and you crash into the ER, ask for a protein called albumin. It's the only place you really can get it. And then the other thing is, if you have high protein in your urine, right, that gives a signs of concern. If your doctor comes in and goes, man, you got protein in this thing more than I've ever eaten, right? Well, if that's the case, well, we should now start talking about anticoagulation. I need to be, and I see some patients through our efforts who are being prescribed baby aspirin when they're just being diagnosed. I see patients who don't have full blown membranous attacks. They're spilling maybe 5 to 8 grams, but they're not even on anticoagulation at 5 to 8 grams. And I think is anticoagulation the thing you go to when a
Mhm.
patient comes in spilling that much protein? Um, because I don't see that commonly prescribed, especially something like a Xarelto, or a baby aspirin is very minimal. I don't think that would have helped me. You know what I mean? Having a full blown MN episode where I'm spilling 12 grams, I don't know if a baby aspirin was going to do it. You know what I mean?
Right. It's a complicated issue, and even nephrologists who deal with the nephrotic syndrome don't know exactly when to start, because there are certainly risks of anticoagulation. And we base the decision on, one, what is the risk of bleeding, right? Is this an elderly patient who has lots of falls or has had brain hemorrhages, strokes in the past? Those wouldn't be good candidates. Otherwise healthy patient, um, sure, there are minimal risks. But as you mentioned, the albumin is linked to the risk of blood clots. And that's generally the risk starts officially. So a normal level of blood albumin is 4. When it gets under 2.8, that patient is at risk for blood clots, and anticoagulation should be considered. Certainly when it's in the ones, which can happen in nephrotic syndrome and membranous nephropathy, um, that patient's at high risk. And most clots happen in the first year after diagnosis, but as you mentioned, sometimes the blood clots are the presenting symptoms. You come to the ER because you can't breathe and you're having pain when you breathe in, and
Yeah.
you're found to have a pulmonary embolism. Um, so we know the most about using warfarin, which is the one you have to go and have your INR
Yeah.
checked multiple times till they get the right level, and you can't eat dark green
It's the
leafy
hardest one to
vegetables.
it's the hardest one to live with, to
Yeah.
take.
And heparin, like the subcutaneous heparin injections like Lovenox also work. It's the things like Xarelto and Eliquis that we don't have as much data, but I think they are being used because they're easier, and they probably do have some effect. Their levels in the blood are affected by blood protein. So if you're losing a lot of protein in the urine, your levels, you may need more of these Xareltos or Eliquis type drugs, which is that's why we don't have a great answer, but certainly studies will be done, and feel more comfortable using those. But yeah, if your blood albumin is less than 2.8, less than 2.5 in the ones, you definitely want to get on a blood thinner to protect yourself.
Absolutely. I totally recommend that as well, man. 8 pulmonary embolisms, 2 strokes, none of
Oh
which
boy.
felt good. I can guarantee you that. I had a collapsed lung on the other side. I mean, it just like it and then to learn that, well, if you probably were just on some kind of anticoagulation, you probably wouldn't have had to go through this. You know what I mean? And that's just a hard pill to swallow,
Yeah.
right? Hard pill to swallow. Um, all right. So moving forward a little bit, I want to reach back out and talk about Rituximab. Rituximab seems to be the number one thing that is helping patients. It's helped me. It put me into what they call a remission state. I'm not spilling proteins as aggressively as I used to. I think I'm down to, I think my last one was 50
Oh
milligrams,
wow.
something like that.
That's
So
great.
something real small, almost nothing, from 12 grams. So, it's helped. But now rituximab in conjunction with some other therapies like Jardiance and stuff like that have really helped come together and lower that pressure in the kidney and reduce some of that proteinuria, which ultimately has turned out to be successful, right? So talking about um, rituximab and building on Steven's question from our FilterLIFE membership earlier, um, when should rituximab ideally be introduced to the, and I know if you've seen one membranous patient, you've seen one membranous patient, right? Because we all present at different stages, whether we present because of swelling or we present because we got a PE, right? Or we present for some other incidents. At what point should rituximab be the doctor's, I think we need to go this route?
So definitely you need to have nephrotic level proteinuria, over 3.5 grams. Um, Generally the blood albumin has to be lower than 4, because otherwise the risk of the immunosuppression isn't worth it. That patient would be considered very low risk for progressing, and we just watch them. If the and you used to have a time window of, okay, you can treat with the agents like the angiotensin receptor blockers like losartan, or ACE inhibitors like lisinopril, the Jardiance. And if you can get the protein under 3.5 grams, then great, you can continue to watch. Um, I like to think about it, if you are a patient that has the anti-PLA2R, you check it at diagnosis, it's 100. Anything over 20 is positive. It's 100. You check it in a month or two and it's up to 150. Even if you haven't waited that 6 months, I think that's a patient that should be treated. The antibody levels are going up in the blood. They're not going to come down spontaneously like they do in about a third of patients. Um, so that patient should be started sort of when you realize that it's going to be a long, protracted disease course. But vice versa, if that same patient, at diagnosis has a level of 100, and then the nephrologist checks it in, 6 weeks and it's down to 30, that patient's probably going into a spontaneous remission, and treating wouldn't have any benefit, treating with rituximab. So you have to make sure that there's immunological activity going on, and that's sort of likely to get worse. There's another group that I wouldn't treat. So the first suggestion is that we test anti-PLA2R. Okay. If you have, 20 pounds of weight gain, swollen legs, 12 grams of protein, you're going to get a kidney biopsy after that. The kidney biopsy might show membranous nephropathy, and it might be some other target, but there are 30 or so far. But if the kidney pathologist stains that tissue for PLA2R and it's present in the deposits and it looks like it's been going on for a while, but the blood is negative for the antibody, that's a patient who had this disease and is on the way to getting better. And that person shouldn't get rituximab.
Got it.
So there's a little bit of nuance in this. And that's why you need to find someone who's treated this, who's familiar with membranous nephropathy.
Now, I'm glad you just said that, right? So I'm a patient. I walk into the ER. How do I find, how do I know that the nephrology guy there that's been there 26 years is not familiar or is familiar? What are some key signs that I can, how do I know?
Yeah. I mean, I think getting to the kidney specialist first, if you're in the hospital and you certainly have pulmonary embolisms and other life-threatening complications, they're going to get a kidney specialist to see you. Most nephrologists, unless they've really been out of touch for the last 20 years, know about the causes of nephrotic syndrome, the testing we can do, the possibilities, the FSGS, minimal change, membranous nephropathy, other rare causes, and can get things started. Because there are general guidelines for how to treat nephrotic syndrome, as you said, albumin infusions, giving the IV Lasix, the diuretics, getting the protein down with supportive therapy. But the actual treatment might require a little asking around, and ask that nephrologist, have you seen a lot of membranous nephropathy, or are you comfortable diagnosing these multiple causes of nephrotic syndrome? And if not, then there may be colleagues there may be colleagues locally in the city that you might ask to get referred to once things get stabilized.
Awesome. Now, so you talk a little bit about the first steps of a nephrologist when they see in this patient, right? And I like to really segue right into here. So I want you to talk now. We're going to talk to the nephrologists themselves, the guys that are at either the ER, they're at the primary care, they're at the nephrology clinics, they're wherever they are, these doctors, right? And they're seeing patients crash into their offices with this life-changing disease that they know nothing about. Okay. What advice do you have for the hospitalists or nephrologists who first encounter a nephrotic patient?
Yeah, I think you have to realize, I mean, getting all of the baseline information is important. So what is the kidney function? What is the blood albumin, as we talked, how much protein of urine? Nephrotic syndrome, the cholesterol can go sky high too, and that is a long-term risk. So sort of getting the basics and realizing, is the kidney function significantly different than it was last time we checked? That may be someone who has acute kidney injury on top of the nephrotic syndrome, or has a renal vein thrombosis. So that can push sort of the acuity of, do I know enough to manage this, or do I need to get my colleagues to help very quickly? I think any nephrotic syndrome should be seen by a nephrologist, either at that visit or within the next week or two, because there are life-threatening risks, especially the blood clots, and treatment needs to be started. I mean, there's some annoying factors like the swelling, the fatigue, the sort of overwhelming fatigue that patients can have. That's not life-threatening, but there are things that you need to get therapy started very quickly. So finding a colleague who knows what this may be, what to do about it quickly, I think is very key. And realizing that it could be the kidneys, because as I said, I've had patients who have had the leg swelling, and the first thing is to set them up with a cardiologist because they're afraid of heart failure, never thinking about the urine might be causing this, the
They
kidneys.
did that to me when I was diagnosed in the heart of COVID. Not only did they think it was COVID because COVID had
Yeah.
no symptoms at that point. There was nothing confirmed. They're like, I don't know, anything could be COVID. Remember that? They're like, if you sneeze, I think you probably got COVID. So when I crashed into the hospital with my disease, that's exactly what they did. And every time after that, right? So when I would get discharged from the hospital, I'd go home, I would do my own routine of trying to manage my own water weight and that kind of stuff. And I would end up back in the emergency room because the water would get too much, and the weight would, and I'd have to go get another albumin injection. It quickly turned into a conversation of when I presented myself at the ER. This is not a heart attack. This is not a heart thing. I have a kidney disease. So it was like a script almost, right? Like I walked into, it was like, hi, this is my name. I have membranous nephropathy. It's a rare autoimmune disease that affects my kidneys, and I'm in a lot of pain, and I'm swelling, and I'm retaining water, and I need these drugs. And I have to have albumin, and I need some kind of Lasix, and I'm probably going to need to be admitted for probably the next 2 days so I can dewater. That's the conversation you have over and over and over, right? When you get there, because so many times you get misrepresented. And then the patient themselves are in so much pain, right? Like think about this, the state of when we have to go to the hospital. Like
Mhm.
all else has failed. Everything we have at home, all of our support system we have at home has now failed. And now we're emergent, and now we're in an emergency room, and we're expecting some type of relief or answer or mitigation to what I'm experiencing. But yet I have to come in and be the educator in that moment,
Mhm.
unfortunately. And that's just some of the willpower that we're trying to teach our following and teach our patients, that we have to crash. When we do crash into there, it's okay. And it's okay to be the educator, because that's what we need to get. We need to get the relief. And sometimes just having the guidance, right? Or knowing what to say when and to who, to the floor nurse or the floor doctor, they're going to come in 8 times. What's wrong with you today? And you're like, I don't know. you know? Um, so anyway, I think that's a really good way of nephrologists attacking this when they see it. They can see it in the form of heart disease. They can see it in the form of lower EGFR. They can see it in the form of water retention and pitting edema. They can see it in the form of blood clots we talked about, and maybe a renal thing, RVT. It's not even a physical ailment. I remember mine. I had been misdiagnosed for like 6 months, right? I had this lower left back flank pain for the longest time, and I kept going in, and I was like, I just think something's wrong. And they were like, well, you should probably get some massages. Like back pain's common with kidney disease, and we'll set you up with the massage therapy and some acupuncture. Well, the whole time, 6 months go by, I collapsed during a football game, that I'm coaching, and I'm on the field. I have to get emergency rushed to the hospital. And now it's an emergent situation because I've had this blood clot in my vein that has just been growing over the past 6 months. Instead of doing imagery and saying, hey, I think this patient's got something probably physically in his body that's going on, let's do some imagery. Imagery would have saved me at that point. You know what I mean? My
Mhm.
first complaint of lower left flank pain. Now, this is not the first time I had been introduced into this disease, right? I had already had biopsies. I had been confirmed membranous nephropathy. I had already had the proteinuria. I had all of these things. So it wasn't new, but it was still a regiment that was, kind of overlooked. So, um,
Yeah.
and
Again,
you
being your own advocate and learning about it, because renal vein thromboses are not common. They tend to be common in membranous, but many doctors don't know that and have never been taught that. Um, so it's, that I'm not going to say the burden is on the patient, but it's, I think for everyone's benefit, learning as much as you can about it. And I've had patients say this is such an isolating experience. Like, I know no one who has this disease. Like, I'm doing this all by myself. I'm having to find a doctor that knows something about it. Um, it's tough. And
so
hopefully
you would
with
you
patient
would
community
agree
network.
that
Yeah.
You would agree that connecting early with organizations, maybe like ones like ours, right? People that can help provide that education, help provide some of that assistance, help you answer and ask the right questions, right? I know for me, sitting in that, what I thought was a deathbed of a hospital bed, being told that I'm not leaving this bed because they don't have any answers. I found organization, I found community, I found people that knew about this disease, you know? Um, and I think that's just really, really important is when you get when it feels isolating, when you are isolated and you have to show up to the table with the most information as possible because we got to save our own lives, right? It's no different than a patient that's already on, like, let's say, dialysis, and they want to get out of that chair and get off of dialysis. That patient's going to have to put in some work to get qualified for transplant, and to it's not easy. There's no easy button to push, and advocacy is not easy either, but it's what has saved my life or prolonged my life and my ability to live with this type of rare disease, is advocacy and fighting for it and asking the questions and putting ourselves in front of the experts like yourself. So this is awesome, man, and it's really, really
Yeah.
good, I think, informative information.
Yeah,
Now
thank
I
you
really want
for this
to.
whole organization and getting the word out, because it is important, and there are others out there that that do this. NephCure is one for patient resources that has a lot of great resources, just all nephrotic conditions. But yeah, there are not many out there that a patient can turn to. So thank you for this.
Yeah, absolutely, man, absolutely. I know it's our founding principles, man. It's why I started our foundation, because it's what I found. I know that's what I needed. You know what I mean? There wasn't a pill. There wasn't an easy button. There wasn't the Rituximab to stick in the vein. There wasn't. I mean, there was just these things that were out there that nobody really knew should be used for me. And what really should have been used for me at the jump was community. I wish I would have been able to find community from diagnosis. Hey, you got diagnosed with this. There's a really good community of people here that have really good information. You can learn in literature and all of that, right? And that would have been really, really helpful for somebody to provide to me at diagnosis. You know, um, it, that's why it's important to what we do, and the awareness is important, so that way we can change those things that are happening in the emergency rooms where these diagnoses are taking place. So I want to segue real quick. We have about 15 minutes left of our interview, and I wanted to transition into a different type of kidney disease, APOL1 mediated kidney disease. And I know that you are very, very informed about APOL1 mediated kidney disease. I'm very interested in it. I know the people that it affects. Maybe you can talk a little bit about what is APOL1, who should be concerned about APOL1, and what are the benefits of, like, knowing whether or not APOL1 is in my body.
Right. Yeah, it's another emerging knowledge area. And actually, PLA2R and APOL1 were identified around the same time. And I think the proportion of the world that's impacted by APOL1 is much, much larger. So it turns out it's a gene that we all have two copies of, one from mom, one from dad. It's an apolipoprotein. It carries lipids around the body. Um, it no one knew about this except for the fact that it fights in Western Africa, where there's sleeping sickness, African sleeping sickness, which is carried by a parasite called the trypanosome and delivered by fly bites, a tsetse fly. Um, there are variants in the gene of ApoL1 that are protective against African sleeping sickness. Okay, so if you have these variant genes, you're less likely to be afflicted by this sickness, make it to adulthood, pass on your genes to your kids. So it turns out, for who knows why, that these same variants of APOL1, and they're called the risk alleles G1 and G2, as opposed to G0, which is the normal form. They became very prevalent in the genes of patients of people in Western Africa, and we think that this emerged 8 to 10,000 years ago.
Wow.
So anyone who has ancestry from Western Africa, who whose great 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 grandparents came to the Americas, both North and South, and the Caribbean islands, much of that happened in the last 1,000 years, but people with Western African ancestry may have these variants. And the problem is these variants can cause kidney disease. They're risk factors. They don't necessarily cause it, but they put you at higher risk for end-stage kidney disease, FSGS, focal segmental glomerulosclerosis, something called collapsing glomerulopathy. And it turns out that looking at, and they've, the recessions on this at Kidney Week in Houston, that there are very strong hot pockets where 40 to 50% of certain villages in Nigeria can have both of the genes. So they have two risk alleles. But in the United States, about 13% of US Blacks will have two copies of the bad kidney risk alleles of APOL1. So that's a lot. That's 1 in every 8.
So what I'm hearing is 1 in every 8 African American persons in the United States could have this APOL1 copy that we don't want,
Right.
or the one that is causing or could be causing some type of kidney disease.
Right. And there are, so for most of us, for most genes, except the ones on the X and Y chromosomes, we get two copies. So we have thought that you need two bad copies, one from mom, one from dad, to put you at risk for the kidney disease. It's turning out that maybe even one may be a slight risk for chronic kidney disease. They're still looking at all the factors and looking at the genetics, but certainly two, and that's 1 in every 8 African Americans. Now you do need another hit, at least, something else has to happen. That can be a viral infection. HIV was, we now know that what was called HIV-associated nephropathy was driven by these APOL1 genes. More recently, COVID has caused COVID-associated nephropathy. And most of these are in patients who have two risk factors, but also things like lupus, kidney disease, other viral infections that we don't necessarily characterize as well, sickle cell disease, even diabetes can combine with these APOL1 risk alleles to push someone more quickly to kidney disease.
Wow.
So it's a big understanding of this, and we don't quite know what to do with it, right? Should everyone be tested? If you found out you have two risks, is that just going to cause you worry for the rest of your life, or can we take steps to protect our kidneys? And I think we're still learning that. And unfortunately, we don't, we need to find the answers quickly.
What would help us find those answers quicker?
I think the global studies that are being done, we know the prevalence, the frequency of these genes throughout the world now, especially in Africa, which is hard hit by kidney disease. There are companies now addressing, also there are genetic companies that make it easy to get an answer. So if you want that, there's some free testing that can be done if you're eligible to being in a clinical trial. That's, it's an easy test at certain labs. But there are drugs being developed. So it turns out that this APOL1 forms channels in cells that ions like calcium and chloride can get through. It used that to kill this trypanosome parasite. It sort of blows them up through these channels, and salts come in and they end up exploding the parasite. But the same thing happens in our cells
It's like
of
a dynamite stick, when they
yeah.
go down the stick dynamite way down in the ground to blow out,
Unfortunately, that may be happening to our own cells, especially the podocytes, which are the cells in our kidney filters that keep the protein in the body and keep it from leaking. So those cells are very susceptible to the APOL1 channels. But certain companies are now developing, a lot of our heart rhythm drugs are channel blockers, calcium channel blockers for blood pressure. They're now APOL1 channel blockers that are being tested in clinical trials. It was so impactful that the first 13 patients or so that were treated made it to this landmark New England Journal article a few years ago, and the company is now extending the trials, and it's ongoing in
That's
their.
good. That's really good. So what I'm hearing is, okay, 1 in 8, possibly mostly African American. Um, are there Caucasian people that could have this? I mean, you said West African descent, right? So with the mixture pot of America,
Mhm.
maybe we could have, maybe there's not just West. How do you know if you have West African
Right.
descent? Are you just black or
Exactly. No, it's Hispanics as well. People Latinos from the Caribbean, Central America, Haitians, um, are at risk, and yeah, certainly you don't have to have the appearance of someone who might, So I think if you have a strong family history of kidney disease, that's often a suggestion. Just, my brother's kidney disease, my dad was on dialysis, my uncle. So it's worth looking into that because that's definitely a genetic,
right? Now,
almost
how does
everyone is
somebody look
just,
into that, right?
yeah,
So if somebody comes to the Enlisted Kidney Foundation and they're like, Dan, I got my grandma had this, my dad's got it. I think I got West African descent. Like now, what do I want to try? I want to see if I have this, right? I want to make sure, see, maybe my kids have it, if I have it, maybe I might pass it down to my child. And now what? Right. So what do we do? Do I go to the doctors or an organization that I should be getting in touch with? How do I get tested for this? And is there costs associated with that?
yeah. There's usually cost, and genetic tests were usually incredibly expensive. Now there are kidney panels, that test for like 400 different kidney genes, APOL1 among them, and there's generally most of that is covered by insurance. Um, am I allowed to say company names here?
Sure. Yeah. I
So
mean,
Natera markets something called Renasight, which tests for lots of genes, but there are other companies that do this. Um, and at the moment, they're doing this for free if you
meet all these
have West
criteria.
African ancestry. If your kidney function is not like ridiculously low, um, because they want to identify people that might be benefit from clinical trials. Um,
Gotcha.
Generally, a kidney doctor knows more about this, but I think a primary care doctor could find the right channels to order this. Um,
Now,
but
what I will
websites,
say is that there's been some history with genetic testing in the African American communities that doesn't have the most positive light on it. What would you say to those people who are like kind of weary about whether or not they should get tested? Is there any benefit from this? Am I just going to get my name added to some registry?
yeah, it's certainly a concern, and we see that at our institution in Boston, that just getting people tested, getting into clinical trials. There's a lot of distrust, which is well earned by the medical community. But I think this is a worldwide problem. And yes, unfortunately, you have to get your genes tested. I think there are some centers that may just only do that test. I think the kidney pathology company Arcana Laboratories in Little Rock can offer exclusively APOL1. So you don't have to have all your other risks. You just find out this particular gene, um, if you have the risk alleles. I think again we don't have drugs right now, but I think being wary of, if I get a viral infection and I start having foam in my urine, I should go see a kidney specialist quickly, or healthier lifestyles, avoiding obesity.
Yeah.
It may
Things that have
change
hurt the
behavior.
kidneys, the foods that you eat, having that awareness maybe, right? Just having the
Right.
awareness that it could affect your kidneys.
Right. And we will have therapies. There are three different channel blockers being tested. There's something that actually suppresses the gene, And then there's one other sort of signaling pathway that's being investigated. And this is just, within a few years of the first drug even being announced. So people are thinking of this. It's a huge global problem, and we'll have answers to it.
Awesome. Awesome. Well, Dr. Beck, this has been amazing, and I just want to let you know we're running close on time, and I want to be considerate of your time. On behalf of the Enlisted Kidney Foundation and our entire FilterLIFE community, I wanted to thank you for your ongoing work and helping bring clarity to this disease, kidney disease, and the awareness and patients who are living with this. Your discoveries have changed lives, man. They've changed my life being in the network with just you and the other organizations that have this kind of information. Is just groundbreaking, and it's amazing, and we're honored to be able to have this conversation and share it with you and our community. For our audience, if you like to help sustain more interviews like this, you can join our FilterLIFE community on Patreon. You can follow us at enlistedkidneyfoundation.org. Dr. Beck, is there anything that you would like to leave our community? Some final words that you would like to leave with our community and the people that are watching this today?
Yeah, well, thank you first for having me. But I think just be aware of your kidney health. I don't think many people really know what the kidneys do, where they are in the body. So just ask your doctor, how are my kidneys doing? And, if the answer is not perfect, then, we nephrologists are a generally nice people, and we like to help, and we like to keep people off of dialysis, which is what I think people fear when they hear their kidneys might not be up to par. So just be an advocate for your kidneys, drink water, keep your kidneys flushed.
Absolutely. Staying hydrated is key. Absolutely. There's so many things out there that want to dehydrate us right now. So,
Mhm.
yeah, absolutely. Well, thank you so much, Dr. Beck. Again, I appreciate your time. I'm sure our audience are going to love this interview. And if there's anything else that we can do in the future, please feel free to reach out to us. If there's any new groundbreaking information that you learn, please use us as a resource. We love to give that information out to our
All
followers.
right. We'll definitely stay in touch.
Absolutely. Thank you so much, Dr. Beck. You take care. Okay.
You're welcome.